Hello. The topic of this presentation is the use of ultrasound in filarial diseases. Human filarial diseases are caused by 8 species of nematodes transmitted by vectors. This table summarizes the characteristics of these infections, their geographical distribution, their vectors and possible animal reservoirs, and some figures about their burden. From the clinical point of view, the two most important human filarial diseases are lymphatic filariasis, caused mainly by Wuchereria bancrofti throughout the tropics and by Brugia species in Asia, and onchocerciasis, also called river blindness, caused by Onchocerca volvulus. This presentation will focus on these two diseases. The life cycle of the agents of lymphatic filariasis and onchocerciasis is very similar. Wuchereria and Brugia adults reside in the lymphatics, while adult Onchocerca worms are found in nodules in subcutaneous and deeper connective tissues. Here, female worms release L1 stage larvae, called microfilaria, which circulate in the blood in case of lymphatic filariasis, while are found in the dermis in case of onchocerciasis. The appropriate vector, a mosquito for Wuchereria and Brugia, or a black fly for Onchocerca, ingests microfilaria during a blood meal, allowing the development of larvae to the L3 infective stage. These are then released onto the skin of a person during a subsequent blood meal, penetrate the bite wound, and mature to adults through several molts in about 1 year. This table summarizes the body localization of adults and microfilaria of human filarial nematodes. To note, adult worms are the pathogenic stage of lymphatic filariasis, while microfilaria residing in the skin and the eye are the pathogenic stage of onchocerciasis. The pathogenesis of lymphatic filariasis and onchocerciasis is complex and not yet fully elucidated. However, in the last decade, major advances in this sense have been made after the discovery that most filarial species causing human pathology, with the notable exception of Loa loa, harbor a bacterial endosymbiont of the genus Wolbachia. In this image, you see Wolbachia bacteria stained in red in the tissues of an adult female worm in cross-section. Phylogenetically related to Wolbachia clades of insects, Wolbachia and filarial nematodes have a fundamental role in their biology. In particular, it is necessary for filarial larval development, adult fertility, and most importantly, adult survival. In fact, the elimination of Wolbachia from the nematodes using antibiotics makes the adult worm sterile and eventually lead to their death in a few months. When released by damaged or dying nematodes, Wolbachia is also responsible for the induction of a potent inflammatory response, which is at the basis of filarial disease immunopathology. Clearly, these facts make anti-Wolbachia antibiotics a useful tool for filarial disease mass control and individual treatment, because it stops nematode reproduction, clears the dying worms from their most potent inflammatory stimulus responsible for pathology and treatment side effects, eventually kills adult parasites, and can be used in Loa endemic areas, where the use of ivermectin is not recommended due to the risk of ivermectin-induced encephalopathy in individuals with high burdens of Loa microfilaria. As mentioned before, microfilaria are the pathogenic stage of onchocerciasis. The death of microfilaria in the skin and in the eye, either by natural attrition or as a consequence of therapy, cause the release of Wolbachia bacteria, with a consequent induction of inflammation responsible for dermatitis and keratitis. In lymphatic filariasis, on the contrary, the release of Wolbachia from adult worms and possibly incoming L3 larvae in the lymphatics contributes to lymphangitis and lymphatic dysfunction. These, and not mechanical obstruction of lymphatic vessels as previously believed, are at the basis of lymphedema and elephantiasis. Let's start with lymphatic filariasis now. The spectrum of lymphatic filariasis pathology is broad, the two main manifestations being lymphedema and elephantiasis, affecting more than 15 million people, and hydrocele, affecting more than 25 million men. Lymphedema has been classified in 7 stages by Dreyer and colleagues, as shown in the panel on the left here. Other rare manifestations include edema of the upper limbs or of the breast, chyluria, and tropical pulmonary eosinophilia. Filarial lymphedema encompasses two mechanisms: inflammation due to the death of adult worms in the lymphatics, causing a centrifugal acute lymphangitis, and inflammation due to superinfection with bacteria or fungi, favored by skin alteration subsequent to lymphatic dysfunction, that cause a centripetal lymphangitis. Actually, it is the repeated attacks of acute lymphangitis of this latter type the main cause of the progression to chronic lymphedema and elephantiasis. Other forms of chronic pathology include hydrocele, which may progress to the even more serious condition of lymph scrotum, and finally symptomatic infected people also show subclinical signs of lymphatic dysfunction. The use of ultrasound in lymphatic filariasis mainly targets hydrocele. Ultrasound is first of all useful to elucidate the parasitic etiology of the hydrocele. Using a high-frequency linear probe, it is possible to evaluate the dilation of the supratesticular lymphatic vessels. The use of Doppler easily differentiates dilated lymphatics from blood vessels. In a variable percentage of infected subjects, the pathognomonic sign of filarial worm moving into the supratesticular lymphatics can be seen. This is called filarial dance sign. In the pulse wave Doppler mode, the filarial dance sign is seen as an undulating band as a function of time with sharp, irregular peaks. Ultrasonography has also been shown to be a useful diagnostic tool to differentiate between diverse hydrocele characteristics with different clinical implication and treatment indication in filariasis. Hydrocele is defined as fluid surrounding the testis in the area of the pole, or mid-testicular, that is more than 0.2 cm fluid collection width when patient is scanned in supine position. The echogenicity of the hydrocele has been associated with the risk of testicular necrosis. Echo-free hydrocele, like the one shown on the upper left image, indicates common hydrocele, while the presence of echo-dense hydrocele, like the one shown on the upper right image, indicates the presence of floating particles constituted by proteins and cholesterol. This is a long-standing hydrocele or chylocele and poses a risk of testicular necrosis. The scrotal skin thickness has been correlated with the type of hydrocele, with a scrotal skin thickness of more than 0.45 cm being an indicator for the risk to develop a lymph scrotum. The use of ultrasound in the assessment of filarial limb lymphedema is more limited. Sonographically, lymphedema due to filarial disease does not differ from other types of subcutaneous edema, and it has the typical cobblestone appearance. The measurement of skin thickness at the level of the external malleolus has been used to evaluate clinical improvement of lymphedema after antivalbuccal treatment in clinical trials in Ghana. Ultrasound examination can also give important information with regard to differential diagnosis of hydrocele. Often, patients with hernia in lymphatic filariasis endemic areas may be misdiagnosed. Also, the finding of dilated lymph vessels and of the filarial dance sign pose a diagnosis of lymphatic filariasis. Let's now talk about onchocerciasis, also called river blindness. His name is due to its distribution along fast-flowing rivers, the habitat of its vector Simulium blackflies. Pathology is driven by tissue-dwelling microfilaria, while non-pathogenic adults reside in nodules, most often in the subcutaneous tissue on bony prominences. Skin disease accounts for the majority of clinical disease, and its spectrum of manifestations is broad. The most common generalized form presents with subclinical or intermittent dermatitis, called acute and chronic papular dermatitis, with troublesome itching. Generalized dermatitis may progress to skin hyperpigmentation or depigmentation, called leopard skin, and skin atrophy. A less common but severe manifestation is a localized hyperreactive form, also named lichenified oncodermatitis or SODA, characterized by pruritic hyperpigmentic hyperkeratotic plaques associated with local lymphadenopathy. SODA is mostly seen in certain endemic areas, such as Yemen and Sudan. Ocular pathology is less common than dermatitis, and its prevalence has dramatically reduced since the introduction of mass drug administration. The most common eye pathology involves the cornea, with punctate keratitis that may progress to sclerosing keratitis and blindness, but other structures of the anterior and posterior segment can also be affected. Ultrasound has only a minor role in the diagnosis and management of onchocerciasis, and it has been mainly used in the research setting. On ultrasound, onchocerca nodules are round or oval, with a capsule with regular margins, and can be found single or in clusters, with sizes from a few millimeters to 1 or 2 centimeters. The content is dishomogeneous, more or less echogenic, and calcifications, if present, may be found in only a part of the nodule, or the entire nodule can be calcified. The main differential diagnoses are lipoma and lymph nodes, which can be easily recognized by the presence of the hyperechogenic hilum. In the research setting, clinical trials on the use of microfilaricidal drugs require surgical nodulectomies to assess the viability of adult worms in nodules after treatment. However, this is an invasive procedure with frequent complications such as infections when carried out in endemic areas. It has been therefore investigated whether the use of ultrasonography to detect the presence of living worms moving inside nodules could replace surgical nodulectomy in these studies. Data from Ghana appeared promising, with 30 to 40% of infected people having moving worms detectable in nodules, and with a statistically significant decline in this percentage after treatment with the adulticide antivolbacchial drug doxycycline. However, our subsequent study carried out in Cameroon found an extremely low percentage of moving worms in nodules, probably due to the different structure of nodules in this geographical area, which have less echo-free areas reflecting the scarcity of fluid component where the worm could move freely. These data altogether indicate that ultrasound may replace surgery in clinical trials of this type, provided previous assessment of baseline data on worm motility is carried out. In this video, you can actually see an adult onchocerca worm moving very slowly inside the nodule. Look carefully on the left edge of the nodule and try to spot it. Good luck!